and thanks for coming to the fourth episode or instalment of the Menzies Youth Type 2 Diabetes webinar series. We have a really interesting presentation again today. I'd like to start by acknowledging the traditional custodians of the lands on which we stand and people are dialing in from across Australia and also overseas. I'm in Katherine in the Northern Territory today, the lands of the Jawoyn people, and I extend that respect to the traditional owners of the many lands on which viewers are dialing in from, and to elders past, present and emerging. And also I'd like to acknowledge the important role that Aboriginal and Torres Strait Islander people have in this project, and also at Menzies more generally. We again have an hour today for the webinar. We have two great presenters today. So the first aspect will be presented by Dr. Matt Hare, who's an adult endocrinologist at Royal Darwin Hospital and heavily involved in the Diabetes Across the Life Course Northern Australia partnership, and does quite a lot of work looking at intergenerational risks as well. And he'll be presenting on management and screening of type 2 diabetes in young adults. And then the discussion component be co-led by Matt, as well as Samaria Corpus, who people may remember from the first session of the webinar, who's an Aboriginal health practitioner in the diabetes team at Royal Darwin Hospital, and a lot of experience in this area of many years, and also a member of the Aboriginal and Torres Strait Islander advisory group of the Diabetes Across the Life Course partnership. Encourage you to put questions into the question and answer box throughout the Matt's presentation and also the discussion component. Please upvote questions that you're particularly interested in, as we will address the questions by kind of order of interest, not necessarily by the order that the questions are written. And both Matt and Samara will kind of answer various questions. There may also be time for kind of case discussion at the end of the webinar, but that component would not be recorded if it happens. But the presentation and the discussion will all be recorded and available for viewing later. And we'll also put into the chat box a link to the Survey Monkey. We'd really appreciate if people could, it takes about 3 minutes to complete, but it would really help us improve the remaining webinar sessions and to meet people's needs and what you're wanting to get out of it. So now the housekeeping is sorted, I'll hand it over to Matt, and thanks very much for your time today, Matt.
Great, thanks so much, Angela, for the introduction, and thank you everyone for coming along today and for the great interest that there's been in this webinar series. It's really encouraging to see the interest that's out there amongst clinicians to improve the way we're looking after young people living with type 2 diabetes and other forms of diabetes. I'd like to just start by paying my respects to the Larrakia people whose land I'm working on today. It's a privilege to live and work here. I pay my respects to elders past, present and future, and also just pay my respects to any Aboriginal or Torres Strait Islander people in the webinar today. So as Angela mentioned, I'll be talking about screening and management of type 2 diabetes in young adults. So I'm an adult endocrinologist, so I guess my gig kicks in at about 18 years of age, sometimes with a bit of blurriness around that kind of 16 to 18 age group. Just a few declarations there. I've worked for a few companies doing advisory boards and things who make some of the drugs that I'll be talking about, but obviously they're not at all involved in the content of this, and any opinions that I give are mine, not those of the people I work for. So just a quick outline of the talk today. I want to start just by putting this in context of the last few webinars and just revisit why it's so important to be having these sessions. We'll talk about screening diagnosis of type 2 diabetes in young adults and how that does or doesn't differ from children or older adults, and have a talk about treatment of young onset type 2 diabetes, again just focusing in on some of the contrast perhaps between children or older adults, and more specifically looking at how do we make decisions around what's the right medication for the patient in front of me, BGL monitoring, a reminder and refresher around preconception planning and counselling, and a quick overview of different types of diabetes at the end, just so we're all keeping our minds open. So there's quite a lot to get through in a pretty short period of time, so forgive me if it's a bit rushed, but there's a lot of stuff that I'm not talking about. And I will lean towards a little bit more talking about pharmacological management of diabetes. I guess that's more my area of expertise, but obviously recognising the real importance of a holistic approach to management, and that first-line strategies are really grounded around nutritional interventions and lifestyle modification, physical activity. But there will be additional sessions within the webinar series around some of those aspects. And there's a whole lot of other things that we could talk about that I really wanted to talk about as I was preparing this talk that there's just not enough time to go into in detail, but feel free to bring up any of these things in the discussion time at the end. So just putting this presentation today in the context of the webinar series for those who've been to the previous sessions. If you haven't been to the previous sessions, they are available on the Diabetes Life Course website. The link's there at the bottom of the screen. I'd encourage you to have a look at some great talks. So first up, Angela talked about what is youth type 2 diabetes, went through some of the statistics and epidemiology and our understanding of the condition. Liz Watkins did a great presentation around talking about diabetes with families and young people. And then we've had a presentation around screening and management of type 2 in the paediatric age group, so up to age 18. And so there's a fair bit of overlap in content in terms of what I'll be talking about today and about the presentation regarding the paediatric age group, because there's obviously some similarities. So just a quick recap on why we're talking about youth type 2 diabetes. As you know, it's increasingly common, and we have some of the highest rates seen globally in Northern Australia. Unfortunately, we know that very few young people with type 2 diabetes are meeting the glycemic targets that we would aim for, and there's a whole lot of barriers with regard to engagement in appropriate care. We know that type 2 diabetes in young people is a little bit different to type 2 diabetes diagnosed at older ages, and one of the key factors is that it tends to deteriorate more quickly, particularly with regard to pancreatic function, so in terms of secretion of insulin from the pancreas out of the beta cells. We know that HbA1c levels tend to go up quite rapidly. You can see this graph here from the Today study, and from a multi-ethnic cohort of young people in the US with fairly rapid trajectory of HbA1c increases over time. This is despite treatment. And we often see quite rapid, for want of a better term, failure of therapies. So first-line metformin, for example, doesn't kind of keep the hyperglycemia at bay for very long. We also know that type 2 diabetes in young people seems to be associated with higher risk of complications than diabetes in older age groups, and probably higher risk of complications than people living with type 1 diabetes. We've got very high rates of microvascular disease at relatively short periods of follow-up after diagnosis in a very young cohort. So we're seeing people with end organ damage in their 20s and 30s, and I'm sure many people online today would see that in their clinical practice as well. Another key aspect of why young onset type 2 is so important is that it's got implications across multiple generations. So as we're seeing younger and younger age of diagnosis of type 2 diabetes, we're seeing more and more young women entering pregnancy with pre-existing diabetes, which has significant consequences, both in terms of obstetric and neonatal outcomes during the pregnancy, but also in terms of the long-term cardiometabolic health of the offspring in the next generation. So there's this intergenerational cycle of adverse metabolic health where each generation appears to be getting earlier onset, more severe diabetes and obesity. And so working with young people to optimise their health and to optimise health of women during pregnancy are key priority areas to trying to reverse this intergenerational cycle. All right, so moving on to the content of today's presentation. How do we screen and when do we screen for type 2 diabetes in young people? As has been covered in previous presentations, current guidelines would suggest that for Aboriginal and Torres Strait Islander young people, we should be screening annually if there are additional risk factors, which includes a first-degree family history or living with overweight or obesity, and that's from age 10. That's the paediatric guidelines. For the adult guidelines, the remote primary healthcare manuals, or the CARPA manuals, push the annual adult health check age group for Aboriginal and Torres Strait Islander patients down to 15. So kind of crossing over the paediatric cohort, but essentially would be advising annual screening from age 15 for Aboriginal and Torres Strait Islander young people, irrespective of additional risk factors. And this can be done as part of the annual Aboriginal and Torres Strait Islander health check, which is funded under Medicare as MBS item 715. There are varying guidelines from other organisations. RACGP's got slight differences in terms of saying screen from 18, etc. But we feel that in our context, from age 15 is appropriate to be aiming for an annual check. For non-Indigenous young people, the current guidelines were just published in the MJA recently, and this is a consensus between the Australian Diabetes Society, the Australian Paediatric Endocrinology Group, and a couple of other organisations, essentially say to screen in young adults with overweight or obesity who have an additional risk factor. And that's from age 18. So how do we screen and diagnose type 2 diabetes? Well, the criteria aren't really any different for young adults as opposed to other adults or even for children. Over many decades, different tests of glycemia have been put forward as potential diagnostic tests for diabetes. And this is a whole talk in and of itself about how people come up with these levels that determine whether someone has a disease or doesn't have a disease. Obviously, diabetes occurs on a continuum where blood sugar levels gradually increase, and at some point we draw a line in the sand and say, well, this person has diabetes and this person doesn't. And there's a whole science around deciding what that cut point is. But it's really helpful to remember that it is quite arbitrary, and that someone who has an HbA1c of 6.4 probably has very similar outcomes to someone with an HbA1c of 6.6. One gets a label of diabetes, one doesn't. But so I think we need to approach these things quite holistically when we're talking about an individual patient in front of us. Obviously, in guidelines and at a population level, we need to have firm cut points and decisions about what is and what isn't diabetes. But we also need to be taking in all the information in front of us when we're delivering care to an individual person. So the diagnostic criteria for diabetes include 3 different tests in the asymptomatic individual. That's HbA1c, which is a non-fasted blood sample. It's a once-off blood test, so it's quite convenient. It can be done on a point of care machine with just a capillary sample from a fingertip. And so that's increasingly used, and I'd advise that that's probably the best screening tool in our context, given its availability and convenience. So the cut point for that is 6.5% for a label of diabetes. We then have this intermediate zone of slightly high levels above normal, but not quite in the diabetes range, which gets given various different terms. We tend to clump all those things together as pre-diabetes. It's not my favourite term, but I'm getting over it. For young people, we tend to use a slightly more generous range for the pre-diabetes cut points for HbA1c, so that captures more people at risk, so pushing that lower end down to 5.7. There's internationally, amongst kind of adult cohorts more generally, a bit of debate about whether that cut point should be 6.1 or 5.7. The Europeans do different things than the Americans, etc. In Australia, for nationally for adults, not just young adults, the consensus is 6.1 is the lower bound. But in the young adult cohort, the recommendation is to pull that down to 5.7 and to advise further testing with an oral glucose tolerance test. The reason for that is that there's fairly good evidence available for the treatment of impaired glucose tolerance, so that kind of borderline levels on an OGTT in the lifestyle intervention for people with impaired glucose tolerance or IGT. It can have significant benefits, both in terms of preventing or delaying diabetes and then subsequent complications. So that's the rationale there. Obviously, in real life, getting OGTT done can be very difficult. So we take a more pragmatic approach, and essentially if someone meets these pre-diabetes criteria and we can't get an OGTT done, we'll just be screening more frequently at, say, a 6-month interval to make sure we get on top of things early, but still offering lifestyle modification, because we know this group of people are at higher risk of progression when they've already got intermediate levels of hyperglycemia. The other tests are either fasting plasma glucose or the 2-hour plasma glucose, which is part of that oral glucose tolerance test. So you have a blood test, drink 75 grams of sugary drink, which is gross, and then do a blood test again 2 hours later. And different cut points are there, as well as the intermediate range for kind of pre-diabetes or high risk of progression to diabetes in the coming years. Now, in a symptomatic individual, the story is a bit different. You don't necessarily have to have as formal a blood test. It could be a capillary glucose of 11.1 or higher. in the context of significant symptoms consistent with diabetes. So that's those kind of osmotic symptoms we describe, which are like being really thirsty, polyuria, needing to pass urine frequently, and other symptoms can include visual blurring, tiredness, and some other non-specific ones. So in a symptomatic individual, a once-off blood test is enough to confirm diabetes, but in general, if it's just a screening test in an asymptomatic person, we would require doing it a second time just to be sure of the result. And that second time can be with the same type of test or a different type of test. It doesn't necessarily matter. Now, in older adults, we do have risk screening tools for diabetes. That includes the main one, which is formed from the AusDiab study called AusD-Risk. These haven't been validated in younger cohorts. So keeping in mind that in the national Australian population, the average age of diagnosis or onset of type 2 diabetes is in the 60s and 70s, whereas in the NT, in remote Aboriginal communities, we see average age of diagnosis of 38. And obviously there's a lot that are happening quite a lot younger than that too. So those scores haven't been validated, but in the national guidelines for older adults, it'd be recommended to do this kind of risk screening tool first, which is just a paper-based thing based on people's risk factors and history. And then only for those at elevated risk on the score, do you do the blood test. For young people, there's less evidence around that and would probably recommend just going straight to the blood test. All right, quickly moving on. So treatment. One of the key differences between youth onset type 2 and type 2 in older adults is the target HbA1c that we aim for. Now, you'd be familiar most likely that a standard HbA1c target in an older adult is 7% or less. Because of the high risk of complications, particularly microvascular complications seen amongst young people with type 2, we aim for an A1c of 6.5% or less. Obviously, this is within the context of the individual person, their risk of hypoglycemia, side effects from treatment, the burden on the individual, all those kind of things. But in an ideal setting, that's what we'd be aiming for. Now, this list of differences that I've got here on this slide come from that recent consensus statement about management and screening for type 2 diabetes in young adults that was published in the Medical Journal of Australia. So I've just flicked through all the things that they raised. They suggested that another difference is the importance of early treatment intensification. That can sometimes mean starting insulin from diagnosis with a view to then backing off and stopping insulin as the other medications kick in. The need for frequent review, so there's constant up titration as required, 3 monthly HbA1cs to be keeping track of glycemic control, and to avoid therapeutic inertia. Now, therapeutic inertia is this idea that we kind of set and forget a little bit. We prescribe something, see how it goes, it's not working, but we'll give it a bit longer again, or oh, that person always has an A1C of 10% and we get comfortable with it. That's therapeutic inertia. It's really important in diabetes that we avoid that and remember the harms of leaving diabetes untreated for long periods of time. The more we work in this space and look after people with very high glycemic levels, we get quite numbed, I think, to those results, but it's helpful to be reminded of what the targets are and what we should be aiming for working in partnership with our clients. Another difference is the importance of considering other diabetes types. Now, not all diabetes is type 2 diabetes, and that's particularly so in young people where autoimmune diabetes like type 1 or monogenic forms of diabetes are relatively more common. It's really important to consider psychosocial factors as well. We know that type 2 diabetes in young people is associated with significant social deprivation, and there are significant barriers to engagement in care. There are issues around stigma, mental health. These are more prevalent typically in young cohorts than older cohorts with type 2. So that's a really important aspect of care. These national guidelines also suggest that after metformin, the best second-line therapy is probably a GLP-1 receptor agonist. So that's semaglutide or dulaglutide, the most common ones, or an SGLT2 inhibitor, the most common ones being empagliflozin or dapagliflozin. That's because these agents have a beneficial effect on weight. They tend to cause some weight lowering. They don't cause hypoglycemia, unlike sulfonylureas like glucagon or insulin therapies. These agents have also been shown in older adults to have significant cardiac benefits and renal benefits that I'll talk about a little bit more further on. The blood pressure target for young people is a bit tighter, aiming for less than 130/80 rather than 140/90 in older adults. The lipid targets are a little bit different, and there's really not great science around these. There's a lot of debate in adults with diabetes about at what point do you introduce primary prevention for cardiovascular disease with aspirin, statin, those sorts of things. But for young people, they're suggesting an LDL target of less than 2.6. And the exercise recommendation is a little bit more than we typically say in adult population, aiming for 1 hour on 5 days per week, but also a focus on reducing sedentary time as well. And where possible for young people with type 2, care should be provided by specialist multidisciplinary teams. And so that is obviously primary care at the centre, but supported by a network of allied health professionals and specialist physicians who have an interest in diabetes, just given we know that it's a particularly high-risk condition with relatively frequent progression to serious complications. Now, my take on all that is that really that's not very different. I'll put an asterisk next to the ones that I think are not different at all. I think we should be looking after all our clients with type 2 diabetes with early intensive management, frequent review, and avoiding therapeutic inertia. We should be considering different diabetes types when things don't fit the typical picture, particularly when you've got patients with low BMI, history of alcohol abuse and pancreatitis. Be thinking about those other forms of diabetes that aren't type 2. We should be thinking about psychosocial factors in all of our patients. This is a massive barrier to care for all people living with diabetes, particularly in the Aboriginal and Torres Strait Islander context. So really important to be thinking about that holistic approach and really working at tailoring our therapy to what's feasible in the individual's context. I think GLP-1s and SGLT2s are probably the best second-line therapy for anyone with type 2 diabetes. It's really just navigating the kind of PBS funding requirements, which makes that a little bit tricky sometimes. So it's not necessarily that different. Quite different from pediatric type 2 diabetes in that once you hit 18, we have TGA approval to be using any of the different type 2 diabetes medications, whereas there's really limited evidence in that younger age group for anything apart from metformin and insulin, which means it's off-label use when we use these other agents. Whereas once you hit 18, miraculously, we're allowed to kind of use what we like, and we adapt a lot of the recommendations from studies that have been conducted in older cohorts. And there's a lot of assumptions there, and we do need more evidence for this young adult context. So how do we choose? If we've got more options than just metformin and insulin, how do we choose what medication? I think my key principles of advice around this are that we need to tailor prescribing to the individual person. We need to think about their comorbidities. Do they already have a bit of albuminuria? Do they already have a slight reduction in their EGFR? Have they got a history of heart disease? Have they got a family history of early onset cardiovascular disease? What are the patient's preferences? Do they like tablets? Do they prefer a once-a-week injection? Is metformin so big they can't swallow it? Would they take a smaller metformin and break it in half? Do they get diarrhea once the metformin dose goes over 1,000 milligrams? In which case, let's just keep it at 1,000 or 500, whatever they tolerate. It's really important that we have these detailed conversations with our patients to decide what treatment is best for them. I think it's important we don't make assumptions, particularly with the introduction of the once-a-week GLP-1 receptor agonist medications. I've been surprised at how many people seem to prefer a once-a-week injection to a daily tablet. But I think as clinicians, we often presume that no one wants to be on a needle. So I think it's really important just to discuss what the options are and tailor that to the individual. Metformin is still the first line in therapy. That's what's been used in all studies. It's always been add-on on top of metformin, and so that remains best clinical practice. But I think it's important to remember that when someone has quite a high HbA1c level or is quite symptomatic at the time of diagnosis, similar to what we'd do in the pediatric context, we should be considering using insulin up front to try and get the glucose levels down, get rid of the symptoms, and then scaling up the other therapies and weaning off the insulin. That's still an appropriate therapy for young adults as well. So we've got a lot of different treatment options for diabetes these days, which is fantastic. We have the ability to tailor therapy to the individual patient with a range of different options available. So as I mentioned, metformin is still our typical first-line option, but sometimes we might introduce insulin or sulfonylurea as well. That's kind of going out of fashion a little bit. Now, when you get to second-line therapy, into adding on a second agent, there's at least 5 different classes, and there's a few others as well that we use even less frequently. And within each of these classes, there are multiple different agents as well. So it's getting more and more complex. While it's good having all this choice and flexibility, it is getting more complex to decide what's the best treatment for type 2 diabetes. Now, this is the Australian Diabetes Society guidelines. It's a very similar version of this that's been adapted into the RACGP Diabetes Handbook in 2020. There are essentially the 3 next best line options after metformin or sulfonylurea, an SGLT2 inhibitor, DPP4 inhibitor, or a GLP-1, with sulfonylurea and insulin being slightly less favoured due to their association with weight gain and hypoglycemia. Now, you see the little addition of these little logos here for kidneys, heart failure, and cardiovascular disease. And this is just showing that in people who are particularly high risk of those things, those agents should be preferenced. Now, the other thing that's making type 2 diabetes management more and more complicated for adults, including young adults, is the massive amount of evidence that is being published every year. And this has been going on really since 2008, when the US FDA said that every new diabetes treatment for type 2 diabetes have to undergo a big cardiovascular safety trial. And this is because there's some drugs around at the time, some of the glitazones that people might be aware of, that they had some safety concerns that maybe they lower sugars but actually increase risk of having a heart attack, which is obviously not what we're trying to achieve. It's not just about the sugar, it's about the end organ complications. And so now we've got all these massive studies being done of all these new agents, and amazingly, both SGLT2s and GLP-1s have shown significant benefits. So not just cardiovascular safety, but cardiovascular benefit. And that's really changed our whole approach and framework for considering diabetes medications for type 2 diabetes. We're not just thinking about glucose lowering and side effect profiles, we're also thinking about, well, what is this individual person's risk of cardiovascular disease? What is their risk of progression of chronic kidney disease? And which agent will help them the most? I'm not going to go through all those trials today. But quickly to talk about these newer classes, we have the SGLT2 inhibitors. So the most common ones we see are dapagliflozin and empagliflozin. These work on the nephron in the kidney. So the kidney is made up of a whole lot of little cells called nephrons that look a bit like this. The kidney is essentially just a filter. The blood comes into these nephrons, and what stays in the tube gets passed out as urine, goes down into the bladder and passed out. But there's a whole lot of receptors all along these tubes that reabsorb things back into the bloodstream once they've kind of gone through the filter of the glomerulus here. Now, your body conserves most of the sugar. So 90% of glucose reabsorption is via SGLT2, this little sodium glucose transporter that's in the proximal tubule here. There's another one called SGLT1, which is a bit further down that proximal tubule, but most of it happens via SGLT2. Now, SGLT2 seems to be just found in the kidneys, and so it doesn't tend to cause other effects elsewhere. Whereas SGLT1, there's quite a lot of those receptors in the gut as well, and so if you block that, you tend to get a lot of diarrhea and tummy upset. So that's how these things work. They essentially keep the glucose inside the tube so that it goes through the bladder and gets peed out. So it's a non-kind of insulin-dependent mechanism. It's got nothing to do with the pancreas. Essentially, once the sugar level in the blood gets above a certain threshold, the SGLT2 prompts it to get passed out in the urine. Now, that explains the side effects that these medications can cause for a number of people, including polyuria or urinary frequency and dehydration, because you're sucking more water out with that sugar as well. So people can get quite thirsty. Bugs like sugar, unfortunately, so you do tend to see higher rates of thrush particularly, so particularly mycotic genital infections, but also increased risk of bacterial UTI. And then there's this rare side effect, probably about 1 in 1,000, kind of over 2 years on average, of euglycemic DKA. So that's diabetic ketoacidosis, traditionally seen in type 1 diabetes. Typically requires hospitalisation, insulin infusions through intravenous drip. The real difference with these is that you can get that condition without the blood sugar looking that high. So you just have to keep an open mind, and the key learning here is it's really important for clinics to have access to ketone strips that are in date, so that if someone on an SGLT2 presents unwell, that the ketone level can be checked. Now, I've got 1 minute, so I'm going to wrap this up pretty fast. GLP-1s are essentially a synthetic version of a hormone that the body already makes. It's called an incretin hormone. These incretin hormones are what drives the pancreas to make insulin after we eat. So we eat, sugar goes into the blood, the GLP-1 communicates to the pancreas and says, squirt out a bit more insulin because the sugar's coming up. There's two hormones, GLP-1 and GIP, that we know of that do this, and there is a drug that affects GIP that will be coming up probably next year. But at the moment we have these GLP-1s. The main ones we use are semaglutide and dulaglutide that are weekly injections. They come in fairly convenient devices. The main side effects people get are nausea and vomiting, particularly at the start, just after they've commenced. Probably about 20% of people will get that. But it tends to wane off pretty quickly over the first few weeks. So as long as it's not too severe, we encourage people just to push through. There are some rarer side effects, including cholecystitis. So people can get gallstones forming if they have quite a lot of weight loss on these drugs. Similar things have been shown after bariatric surgery with massive weight loss. There's a theoretical risk of pancreatitis, so we always have some caution in people with that past history. And then with semaglutide, in one study, there was shown to be a worsening of retinopathy in people who had really high HbA1c levels at the start and already had some eye disease, that when they had a rapid improvement in the HbA1c after starting semaglutide, that the retinopathy actually got worse. Now, we've seen that in type 1 diabetes trials in the 90s, that if you rapidly improve someone's glycemic management with type 1 diabetes, that some of the microvascular complications can temporarily get worse. In the long term, there's still a benefit, but it just reiterates the importance of being up to date with eye checks. So everyone with type 2 diabetes should be having an annual eye check. And if you're going to start a semaglutide in someone who's got a high A1C, you'd want to know that they've had their eye check in the last 12 months. We've already touched on this, but these newer agents have not just cardiovascular safety, but there's evidence that they help prevent heart attacks and strokes and heart failure in people who are at very high risk. That's all been shown in older adults, not in young adults. So we're really extrapolating when we're using these drugs in younger people. GLP-1s in particular are very good at lowering weight. And so many people with type 2 diabetes are also living with obesity. And so this is a really helpful therapy too. So gone through that, there's a lot of options, but that's a good thing because we can tailor our therapy. Just quickly, do we have to monitor BGLs? I would argue that it's a useful educational tool for a lot of people, but it's not essential unless someone's on a therapy that can cause a hypo. So if someone's on insulin or sulfonylurea, then I think they should be monitoring BGLs. Definitely people should have access to glucose monitoring so that if they are unwell, they can be monitoring their BGLs. But for other people with type 2 diabetes who aren't on these agents, I think HbA1c checked 3 monthly is a good marker of diabetes management. But sometimes little short bursts of just 3 days of doing more frequent monitoring can be quite helpful prior to a review, just to get a sense of people's glucose profile. Quick shout out to not forget pregnancy. Young people are obviously more likely to get pregnant than old people. And it's a really important conversation to be having upfront with our clients, and to be advising the importance of contraception, particularly if on medications that aren't safe during pregnancy, which includes all those newer glucose lowering ones. There's just not the safety data available. So really only metformin and insulin are considered safe. In some places there's comfort around using sulfonylureas as well, but I'm a little bit more hesitant with that. So most guidelines would recommend using long-acting reversible contraception, so intrauterine devices or Implanon, for example, for people living with diabetes. But it's also really important to counsel young women about the fact that if they are starting to think about pregnancy planning, that they do engage with the clinic and with their diabetes support team around how to optimise their health prior to conception. We'd be aiming for an HbA1c of less than 6.5% and aiming to start folate supplementation, ideally 3 months pre-conception. So I think because I'm over time, I will hold off on this, but the message really was just that not all diabetes is type 2 diabetes. I've played around with the youth type 2 logo there. I hope you guys don't mind. But so many of the clients I see day to day do not fit into these traditional boxes of type 1, type 2, or even kind of what was known as type 3 diabetes or other diabetes relating to pancreatic disorders. We're seeing more and more of these hybrid forms. That's now recognised by the World Health Organization as a type of diabetes, but there's lots of different types of that. So if there's time, I've got kind of 4 or 5 cases that kind of don't necessarily fit the boxes, some that do, some that don't, but perhaps we should open up for discussion first.
you, Matt. Hi, it's Liz here. I'm just jumping in for Angela. She's been called out to an emergency. So I will get the discussion started. I've got Tamara Corpus here with me, who you've all met from a couple of webinars ago. If everybody could please vote on the question and answers if they'd like to see their case studies or if they have any questions. I'll just give you a moment just to write your questions, and then we'll talk about the most voted questions.
Looks like we're getting some votes for case studies.
Lots of votes for case studies, yes.
Thanks, everyone.
Let's see.
Mara, before I jump into that, did you have anything you wanted to add?
Yeah, with your targets of HbA1c, by the time they're diagnosed, we're seeing them much higher. They're more or less from 10 to 12. So, yeah, we have to do a lot of quick thinking to get them down straight away because of the complications. So, yeah.
Yeah, I think that's a really important point, because it indicates that we're probably not screening as much as we should, because we don't seem to be picking many people up at 6.6. We seem to be finding them down the track. And most of the time that it takes time to progress to those sort of HbA1c levels. So probably need to be screening more, so picking up earlier. But yeah, then we've also got a long way to go in terms of treatment, because metformin alone, it may get things under control, but not very fast. So we probably need to, yeah, be kind of more intensively managing upfront.
And I think any like one risk factor, you know, obesity, we should be looking at and screening earlier.
Mm-hmm.
Yeah, definitely.
And
I think
history.
Yeah, I think once you hit age 15 for Aboriginal and Torres Strait Islander people, I'd be recommending screening annually, irrespective of other risk factors. But unfortunately, most families do have a family history, or there's issues with obesity and things. So there are a lot of risk factors out there.
Yep.
Okay, we've got a question here. Are all kids with type 2 diabetes treated in tertiary centres in Australia?
That's a good question. I guess, should all kids be managed in a tertiary centre is probably more of the question, I think. I'm sure there's a lot that is slipping through the cracks, unfortunately. And it's particularly difficult in Northern Australia, I think, with just the geographic spread and the lack of access to specialist paediatricians. But yes, essentially for children, so all children should be managed by a specialist if they're living with type 2 diabetes. For young adults, that kind of 18 to 25 age group, I would argue that we should also be involving tertiary centres, because we know that the outcomes are significant. And I see patients all the time who are on dialysis in their late 20s and early 30s, and a lot of them haven't had any involvement with tertiary level care, often for a decade before that, and then they're kind of getting referred and it's too late to do much about it. That's not to say that it's primary care's fault or anything. It's mostly that people in that age group haven't really been engaging with the clinics and things anyway, so that option for referral hasn't necessarily been there. But I think we should be advocating for primary care-led care for young adults, tertiary-led care probably for kids, but obviously in close partnership with primary care.
Another statement here that if we screen and have a huge number of kids and youth with type 2 diabetes, how could we manage that?
Yeah, I think we need to be adapting our services to the need, really. I mean, I think we certainly shouldn't be avoiding screening because we worry about our capacity to look after it, because we're just delaying the problem. We'll then be screening everyone for their chronic kidney disease and their heart disease in 10 years' time, and having that burden on the health system instead. We know that investing in management of chronic conditions like diabetes early will actually reduce burden on the healthcare system in the long run. And so I think we need to keep advocating for that and making sure that we actually have the adequate resourcing to do it, which unfortunately in a lot of remote Australia we don't.
And I think it's really important if you're going to pick up huge numbers in a community, that's where I think the community needs to get involved and promote healthy lifestyles, exercise programs. So it also has to come from the community. You know, look at what's happening in that actual community.
Yeah, I just see a little comment pop up there about tertiary care not being the best place for culturally safe care, and I completely agree. I think primary care, and particularly Aboriginal community controlled primary care, is where the bulk of support and multidisciplinary care should be happening. I think it's just, yeah, the message is to involve the specialists as well for kids living with type 2 diabetes, because it is pretty complicated and we often need to use off-label medications, and it's probably not appropriate to be going outside of TGA recommendations without involvement of a specialist for advice. But that needs to be locally adapted in terms of what that model of care looks like and how it works. Is it telehealth? Is it case conferencing? Is it outreach visits? Do people sometimes get brought into town? That has to be tailored based on the setting. And definitely for adults, I mean, our approach is generally to push most type 2 diabetes management out into communities, but I think in this young adult context and with the increasing complexity of medication choices for type 2 diabetes, we should also have specialist support available. That's my feeling. But definitely not that tertiary should in any way take over. We should take a back seat.